Okay, so what are the non-surgical techniques we can use for angular limb deformities? So box rest for 4 to 6 weeks with looking at the row parameters, so just showing you the word again, every 2 weeks, and then controlled exercise. You can use splints and casts, but just make sure they don't incorporate the foot, so this is wrong, this is fine. And basically you frequently change these casts every couple of weeks and make sure it's well padded as well to prevent pressure sores. You can do hoof trimming with foot extension, so it depends on the abnormality you have. So let's say with valgus deformities, remember the outside hoof wall is facing out, so the outside hoof wall should be lowered, so this part should be lowered, and the extensions are placed on the medial side. In varus deformities, you have a pigeon toe conformation, so the foot's going in like that. The inside hoof wall is lowered and extensions are placed on the lateral side. Okay, so now we have surgical treatments of angular limb deformities. The focus is growth acceleration by periosteal transection and elevation. It's performed on the concave aspect of the limb. So basically the lateral side in, let's say, the valgus deformity case, and the medial side in the varus deformity case. So when it says on the concave aspect of the limb, what it basically means is when the limb is this way or this way, what's sticking out more, you do the transection through that. And yeah, it's just showing you some pictures here. Yeah, so after you do these treatments, look at the improvement. You can basically see there's less laxity of the joints, everything straightened out with the shoeing. Anyway, so there are more surgical techniques, of course, for angular limb deformity. So there's also growth retardation cases. So we can put implants on the convex aspect of the bone to bridge the physis temporarily. So basically here and here. This should be performed in young foals less than 3 months of age with severe ALD, so angular limb deformities, or in foals with significant angular limb deformities in a bone after the rapid growth phase is over in metacarpal bones 3 and metatarsal bones 3. And it also says P1 after 2 months, the tibia after 4 months, radius after 6 months. So remember 2, 4, 6. P1 tibia radius. Yeah, so it just shows you what that's going to look like after. Right, so why would a single transphysial screw be helpful for angular limb deformities? Well, if you put a, let's say, 4.5 millimeter cortex screw through a stab incision using a precision screw technique from the metaphysis across the physis into the epiphysis under, let's say, radiographic or fluoroscopic guidance, the screw should be placed as much perpendicular crossing the epiphysis as possible and staying in its outer fourth region. And transphysial bone plate, so this is before, you use a small 2.7 millimeter 4 to 5 hole bone plate, and so you can see there are 4 holes in this bone plate, and yeah, this shows 10 weeks after correction of the deformity, and it's just night and day really, isn't it? Okay, next we have corrective osteotomy or ostectomy technique. So there are 3. You have the wedge step and derotational step ostectomy. So the wedge, the bone wedge is removed from the horizontal plane near the physial region. So this is the wedge technique. So you take like a small wedge out and you remove it. And it's kind of in the name. Wedge, this is what you have, and ostectomy, this is bone removal. And it's removed from the horizontal plane near the physial region, so near where the epiphysis ends. Step ostectomy, so this is the wedge is removed from the center of the metacarpal 2 bones. I'm trying to find something, and in the sagittal plane. And then you have derotational step ostectomy. So I assume maybe this is step ostectomy, but derotational step ostectomy is when you remove a vertical wedge with its wide aspect located either dorsally or palmally to correct rotational deformity. So I think this is derotational step ostectomy, and I assume maybe this is step ostectomy maybe. So step ostectomy, just to recap, is the wedge is removed from the center of the metacarpal 2 bones in the sagittal plane. Sorry, 3, it's always 3. With derotational step ostectomy, you remove a vertical wedge with its wide aspect dorsally or palmally with rotational deformities. And there's the 4th technique, I just didn't see it, is step osteotomy. So everything else was an ostectomy. This is the only osteotomy. So you do a Z-plasty. So let me show you. On the frontal plane, and the fragments are rotated into alignment, basically. Yeah. I don't know how to show it to you better than that, so I'm really sorry. Yeah, so you have sagittal step ostectomy. So remember, we did the 2 lines that bisect, and you get the angle we mentioned, and then you basically correct it using your bony plates and screws. All right, so flexural limb deformities. Okay, sorry, I know this is just a boring slide. So flexural deformities, they usually occur in growing horses where the joint is in an abnormally flexed or extended position. So what you get is, as you can even see here, hyperextension and hyperflexion. This affects the soft tissue structures in the sagittal plane, and the opposite. And as opposed to like angular limb deformities, which primarily affect osseous structures in the frontal plane, yeah, of course, this affects soft tissue structures in the sagittal plane. And usually the forelimbs are affected. So this is similar to navicular bone disease in that sense. When we're talking about flexural limb deformities, it can be born with, it can be acquired. So these effects are usually on the metacarpophalangeal joint, or the carpal region, the tarsal region, or the metatarsophalangeal joint, the distal and proximal interphalangeal joints, congenital lateral luxation of the patella. Yeah, it can also result in a flexural deformity of the stifle, so the stifle being hyperflexed, so inwards. And you also have acquired flexural deformities that affect the distal interphalangeal joint. Oh, now we know what that is, DIP, distal interphalangeal joint, and MCP joints. So how is it caused? Well, we did say there are congenital and acquired causes. I think what we'll do, we can just say this and then we'll go into it afterwards. So the congenital forms, teratogenic agents, so things that affect fetuses basically, intrauterine malpositioning in large foals, genetic issues, diseases from the mare as well, like issues with the thyroid like a goiter, influenza, neuromuscular disorders, issues with the collagen and elastin by plant toxins. Acquired, so this is after the baby's been born, you have orthopedic diseases. So what happens is when there's longitudinal growth of bone, it can be greater than the tendons that they have. So the tendons are too short. You also have unyielding accessory ligaments of the deep or superficial digital flexor tendon, and contraction of the musculotendinous unit because of pain or prolonged flexion or not bearing weight. And continuous overload or ruptures of the flexor tendons can induce hyperextension. So basically, excessive loads can lead to hyperextension. And if there is pain that the animal is experiencing, they'll flex too long and not bear weight, and this leads to issues. Okay, so we'll stop it here, and afterwards we'll continue with congenital.